Yuichiro Nakai is an endocrinologist and part of Northern California Medical Associates. He is now residing in the cardiologist's office, so we see him every day and hear him interact with his patients, and he really does a great job in caring for them. He received his MD degree from St. Louis University, did his residency at UC Davis, and then an endocrinology fellowship at UC Davis. He's currently the director of endocrinology at Diabetes and Metabolism Division of Northern California Medical Associates, and is very key in our development of disease management. Certainly a major cause of morbidity in our country and in Western countries is type 2 diabetes, and the management remains difficult. The puzzle of medications available to treat this disease has become increasingly complex, and Dr. Nakai is here this morning to shed some light on that and help us with that. So, Yuichiro?
Great, thank you very much. So I was asked to speak and wanted to come up with something to talk about, and as I was thinking about topics, I was thinking back that I've had a few doctors tell me that diabetes used to be easier and that it's gotten much harder, and some of that is because there have been so many new medications that have come out, and that the guidelines on when to choose which ones are, to me, not terribly helpful. So I decided to try and do a talk about selecting type 2 diabetes medications, and there are some limits about this talk, and that's number one, I'm going to talk about type 2 diabetic medications, not really any on type 1 diabetes. I'm really not going to address insulin management of diabetes. This is going to be solely about drugs and what we know about them in adults, because there's very little known about type 2 diabetes treatments in kids, comparatively speaking. That this is going to focus on routine outpatient management, not focusing on the one day someone's having a surgery or when they're in the hospital. And that while this talk is going to talk about medications, I think lifestyle is the most important. I have had some patients, the greatest successes have been sometimes where they come in, I don't do anything to their medicines, I finally get through to them about lifestyle change, and the A1C drops by like 3%. So the lifestyle is very important. So I found this little cartoon that you can read. Patient comes in, doctor says, here's a bunch of drugs, even though she's saying, I want to do diet and exercise. So basically, would prefer not to be this guy and to still focus on lifestyle management. I am going to talk very quickly. I have lots of slides because I found out that if I'm going to try and cover the diabetic medications, I felt that I had to cover almost all of them to give you some comparative if you're going to decide on which one you're choosing for patients. And so apologize for the pace. I'm also going to try and give you a lot of more up-to-date information, even for some of the older drugs. I'm going to also assume that we can agree on some basic concepts, and so I apologize if there's a little lack of detail when I discuss some of these slides, but they're there in your handout for reference. So number one is that, of course, diabetes is becoming more and more prevalent, so we can see between 94 and 2010 increasing numbers. I had this slide that said diabetes population, but this is old, of course. Actually, on the prior slide, we see that the prevalence is thought to be around 8% of the population in the United States. This is based on the 2011 data that's available. I also want us to agree that diabetes is probably not good for your health. It's one of the leading causes of death, listed as 7th. It's highly listed on death certificates in terms of dying from macrovascular disease, the heart attacks and the strokes, and that men and women with diabetes have a significantly increased risk of dying from macrovascular disease, heart attack and stroke. Then there's microvascular disease, and during the course of the talk, I think very quickly we'll see why there's this distinction between these two. But it's still a leading cause of kidney, eye, and nerve problems. We go back to some of the very early studies that finally showed definitively that treating diabetes actually helped with these things, because this stuff was actually not definitively known until the 1990s. And prior to that, there was actually argument about how helpful it was really to lower glucose. So back to UKPDS, which was one of the early big studies in type 2 diabetics, primarily using metformin and sulfonylureas and insulin as the means of treatment. We see that peripheral vascular disease and microvascular disease, big reductions per each percentage point decrease in A1C, much less robust when we deal with heart attack and stroke. This is looking at the type 1 diabetes data. Again, this is all going to be insulin management, so this is not drug choice related, but again, we're going to see in terms of microvascular disease, clear improvements in rates of progression of these disorders as the A1C gets lower and lower, and the original goal of A1C of about 7%, and this has been modified, so we're shooting for a little bit lower than that if we can get there safely in patients. So which of the type 2 diabetes drugs is really going to be best for microvascular complications, or does it matter at all, and is it purely limited to lowering the A1C? And the answer is we don't know. So this is where there's a study that's out in progress now where we're going to look at these different drugs. We're still a ways away from getting the data if there's any of these drugs that's any better for those microvascular complications. So a lot of the talk from here is going to deal with what we know about overall risk and cardiovascular complications. And going back to UKPDS, more recent, this is the older data, again, showing that there's appears to be a decrease in fatal and non-fatal MI with lowering A1C. Then we came to the Accord study just in the late 2000s, which said, wait a minute, are we really convinced with this? Looks like maybe an increase in mortality, an increase in cardiovascular death for patients who are aggressively treating with these type 2 diabetes medications. I'm throwing in at the bottom, even though in this circumstance we still show that improvement in microvascular disease, the retinopathy, more recently published in 2010, showing the hazard ratio of progression of retinopathy decreasing with improving glycemic control. That same Accord study that raised the question of increased mortality shows that that increased mortality really does track with hypoglycemia. So a second major point of the talk is hypoglycemia bad. So this is where in the intensively treated group, versus the standard treatment group, the risk of overall mortality was not that different. Once we get to the treatment groups with hypoglycemia, we see that the risk of having severe cardiovascular events was going up. We do know that intensive control can improve cardiovascular outcomes. So this is a Steno-2 trial, which is dealing with type 2 diabetes, but then in combination with lipid and blood pressure therapy. This was really not designed to isolate the improvements from glucose control. The reason why I have this slide up here is to show that to really get a pretty clear distinction in cardiovascular outcomes, it takes a while. And that Accord study was only about 3.5 years in length, so maybe really not long enough to really see benefits. Similarly, when we go back to, again, DCCT, which is insulin therapy in patients with type 1 diabetes, so this is not a problem with type 2 diabetic drug medications, we see that there is eventually an improvement in cardiovascular outcomes where the risk of major adverse cardiovascular events in the conventional treatment arm is clearly higher, but it takes several years to start to get that separation. So 20 years ago in 1994, this talk is very easy. We're talking about sulfonylureas and insulin. I can move under the light if it's better for you. Now we get to 2014 where the list is just a little bit longer. And so we'll try and cover most of these here. In 2008, and this is a response probably to what happened with Avandia as a concern rose, which we'll briefly try and hit, the FDA then comes up with, you know, maybe for approving these drugs, we have to show that they actually don't cause people to have more heart attack and stroke. So the problem that we're going to have looking back at the drugs from before 2008 is there really isn't a whole lot of long-term cardiovascular data to look back on until we get to more recent studies. We went from initially having sulfonylureas and insulin, so we were primarily doing insulin replacement, to in the 90s adding the biguanides and the thiazoladinediones back in with effects on the liver and peripheral glucose uptake. And now we're to the point where we have many different sites where these drugs tend to work. I'm throwing this slide in. This is, I think, another one that I would ask you when you're thinking about patients, especially for those who have a limited budget, who have a drug cap, who have a high deductible plan, who don't have insurance. So I actually see some patients who still come back and see me who are completely uninsured, and I'm purely sticking to this part of the drug regimen for obvious cost reasons. And as we get later in the slides, you can maybe look back and see what some of these other drugs that we're talking about end up costing on a monthly basis, care of GoodRx.com. And for patients who are struggling with financial issues, I ask them to look here. Sometimes you can find little deals, even like insulin. According to this website, Walmart will sell you regular insulin for $25 a vial, which is 1/3 to 1/4 of the cost of what you can find other insulins other places. There are some guidelines that have more recently been published by the American Diabetes Association and the American Association of Clinical Endocrinologists, which I'll refer to as ACE from here. There's a lot of overlap, and these are in your handouts as well. You can read their articles backing this. And the ACE guidelines at least has this little table of drug class versus their listed risks here, and giving you blue, we don't think that there's a problem, green, good, red, bad, and yellow, have caution. They then put this together into this like, well, pick one, pick two, pick three, kind of move down this algorithm. At any point along the way, you can always add insulin, and if your A1C is very high, maybe think about starting with 2 or 3 drugs from the beginning. The only consensus between these and any other recommendations that are out there, also from the EASD, European Agency for the Study of Diabetes, and the International Diabetes Federation, is that metformin is #1 treatment, and I hope to show you why in just a few minutes. And then as the green bars decline, the green is good, but maybe a little bit less so as we go down here, more caution in terms of picking drugs. Here's the ADA one. I don't find this terribly helpful just to look at this itself. It basically says, hey, metformin, and then pick something else, and gives you a little bit of information on the side about what some of the bigger risks and benefits of these drugs are going to end up being. I'd ask you to look over this as well. Basically, they say individualize. This is, hopefully we can spend a little bit of time talking about that. Metformin, #1. After metformin, you know, we are sort of guessing. We don't really know which one is necessarily the best. This is why it's sort of vague in the guidelines. And that basically that comprehensive cardiovascular risk reduction is really needed. We do have data on lipid lowering and blood pressure lowering for heart attack and stroke. So metformin, I think this is my oldest slide in the whole deck. 1987, it works, A1C comes down. Enough said. Okay, myocardial infarctions. This is going to be data from UKPDS on metformin. Hazard ratio for having an MI, less than conventional diet control. So less MIs. Overall risk of dying, less. So patients come to see me and I add on other drugs and they say, you're going to stop metformin? And I say, usually not. I think you have less chance of dying. And they say, I like a less chance of dying. So I usually leave them on metformin. So using metformin early is also probably good. So this is UKPDS. This is released later in 2005. This is where the trial ended. The A1C went back to the conventional treatment group. And still, when we come back later on, we're going to see that there's ongoing relative risk reductions in major cardiovascular and all-cause mortality with prior metformin use intensively compared to diet and control. So I like metformin. I like metformin early. Where should we not be using metformin? There was a lot of concern about use in heart failure. Again, recent data. This is a review published in 2013 of 9 studies. A lot of patients. We're taking people who have a risk for lactic acidosis. They have heart failure, mortality with metformin reduced versus control. Control here is mostly sulfonylureas, which we'll get into briefly. Mortality with people who have reduced EF. These are the people probably even more at risk for lactic acidosis, a possible trend towards improvement. No increased risk of lactic acidosis is a lot of patients. And their conclusion, this isn't mine, until other trial data come out that's more definitive for another drug versus metformin, that metformin should be the drug of choice in patients with diabetes and heart failure. A prospective study in heart failure, a fair number of patients, we're going to see that this is survival higher with metformin than without. Seems good to me. Again, this is patients in heart failure. The risk of deaths, 0.76. Lower than Unity. We think this is probably real. Maybe a little out of order on this slide, but I threw it in here anyways. Canadian Diabetes Association, their 2013 guidelines are recommending this in patients with heart failure all the way down to an EF of around, a GFR of around 30. So this is where a lot of people are pulled off out of concerns. So what about that concern about lactic acidosis? Geez, we shouldn't use this. We're worried. And I've had people tell me, you know, pick a safer drug for this patient than metformin, such a high risk. And I say, I don't have a safer drug. Cochrane Review 2010 pulled data of just a couple studies, 347. Lots of patients, lots of patient years. The risk of lactic acidosis, 0. The confidence interval from -5 to +4. So the worst case scenario of that confidence interval is we have about 4.3 cases per 100,000 patient years. Not much. How does that compare to other non-metformin treatment groups? It's about the same. So this is not a blazing risk of lactic acidosis with metformin use. They're saying that the only evidence of an association with metformin and lactic acid is going to be a case report of 330 patients. This is, again, not me. This is Cochrane Review. This all risk seems to be really tied to the past history of metformin, a related drug that worked somewhat differently in the liver and did have an increased risk of lactic acid production. So metformin, good. We'll get to hypoglycemia risk, really not much. Seems to reduce cardiovascular and death. I like it. Moving on. Sulfonylureas, been around since the 50s. Discovered incidentally, works on the sulfonylurea receptor because they found the receptor after they found the drug. And works by causing degranulation and insulin release, which primarily increases basal insulin secretion, meaning more insulin all the time, not specifically when you need it when you eat more meals. Large ranges on how much we think A1C is lowering depending on the starting point and the population chosen. Numerous retrospective studies now showing monotherapy with sulfonylurea versus metformin showing an increased risk of not doing so well, little thing called dying, increasing, so this is not necessarily the best drug. And you'll see going back to that ACE guideline, sulfonylureas are all the way at the bottom in terms of their recommendations for choosing them. And are all of these the same? There may be some studies that don't show mortality benefit based on choosing different ones. But in specific cohorts, again, these are all retrospective studies, so take it for what it's worth. Glimepiride may be a little bit safer. Some cohort studies looking at glyburide versus glimepiride shows increased risk with glyburide. Glipizide versus glimepiride, again, maybe some increased risk with glimepiride. In my specialty practice, I tend to think of all of them as high-risk cardiovascular patients, so I'm not a big fan of these drugs typically. I will say I still have a few people on these because when I try and take them off, sometimes they really get upset when their blood sugar goes up a little bit before we've done something else. Glyburide, my least favorite. I really try and get patients off this at least once, and again, I do have some patients who go back on. Any hypoglycemic versus other sulfonylureas, relative risk ratio with glyburide higher. And major hypoglycemia may be a trend towards being higher, the confidence interval crossing unity. Why is this? Potentially related to much longer half-life and being metabolized into products that do also have hypoglycemic effects, as opposed to glipizide, much shorter, primarily hepatically secreted and less in the urine, so you're dealing with the older patients who are starting to have some decline in renal function. And then glimepiride, intermediate half-life, but completely metabolized by the liver. So meglitinides, I tell patients that these are like short-acting sulfonylureas. They don't work on the sulfonylurea receptor. They bind on a different site. I'm unable to find any long-term studies, so there's not a whole lot of slides about this. A1C lowering is probably a little bit less robust than with sulfonylureas, but as they're not as long-acting, we get less hypoglycemia. And there are two on the market, repaglinide and natiglinide. Repaglinide is a little bit shorter in action with more bile secretion versus longer acting with more renal secretion. So again, for the older patient beginning to have some renal insufficiency, repaglinide might be a little bit better, but if you go back to cost, it's about twice the expense. Thiazoladinediones. So again, A1C comes down, they work, they lower blood glucose. The reason I have this slide up here is this is going to compare sulfonylureas, metformin, and TZDs. And so we're going to see that sulfonylureas work really great initially, and then the effect wears off. You can only flag the pancreas so hard to keep putting out more and more insulin. Metformin and, in this case, rosiglitazone, we get A1C lowering. And one of the important things is diabetes is a race, more like a marathon than a sprint. So over the course of years, we see a persisting glycemic benefit, most so with the TZD, and then somewhat secondarily with metformin, but we start to see some decline. So why do we not use these as much? Patients don't like them because they gain weight. This weight gain is real. It's seen in studies in addition to what patients come in and complain about. It does appear to be dose and time dependent, and there are several reasons why patients may be gaining weight with these drugs. Now, this is the 2007 retrospective study released by Nissen in the New England Journal that basically killed rosiglitazone. Basically saying that, look, the odds ratio for MI appears to be higher than unity and pretty high, and that the odds ratio for death is high but crossed unity. Much less fanfare, but there's been recent, again, 2013 prospective study that was reviewed and analyzed by the people performing the study, and they had an independent review, both of them agreeing there doesn't appear to be an increased risk of these major cardiovascular outcomes other than congestive heart failure, a known problem with this class due to fluid retention, with hazard ratio right around 1. And again, there may be a trend towards actually decreased risk in death. This actually goes along with other studies, even with rosiglitazone itself, where with the VA Affairs diabetes trial, again, here's my risk of having cardiovascular disease death being unity. We are better than that with rosiglitazone, so it's better to be on it than not. Here's the same thing with pioglitazone. Death, MI, or stroke, these are pretty big outcomes. This is less than 1, and the confidence interval is less than 1 as well. And we do see the heart failure is going to be higher than with control. Again, there is known fluid retention with this drug. So some of the other things that patients now ask me about with the use of this medication is fracture, because that's been out there. There does appear to be an increased risk of fracture with these drugs. The hazard ratios seem to be relatively large, I mean almost 2, and it may be a little bit more with pioglitazone than rosiglitazone, but the absolute effect of this is not huge. So there's differences between relative risk and absolute risk, and in this situation, number needed to harm over 3 years means 86 people prescribed to get maybe 1 more fracture. So it is out there, but it's probably not huge. About a year ago, I think the French put something out that made the news about pioglitazone and the increased risk of bladder cancer. So there is some data on this, again, retrospective cohort studies, showing that there's a pretty big hazard ratio increase with pioglitazone, more so than rosiglitazone. But again, looking at the absolute number of cases, this is not a large number. So their meta-analysis conclusion is there may be a modest increase in bladder cancer. And basically, if there's prospective studies confirming this, we have to reevaluate the cost-benefit ratio of using TZDs. So newer classes to the drug. So far, we're all still pretty old school. The DPP-4 inhibitors coming out when I was still in training. I'm going to talk about mechanism of action along with the incretin mimetics, because they're working in the same general system. And the incretin mimetics, which we'll get to, are going to be that our intestines make these hormones that have effects on the stomach to slow gastric emptying, on the brain to say I'm full, and on the pancreas to increase insulin secretion largely in a glucose-dependent fashion. So when blood sugar is higher after meals, we get more insulin. This is where we want it. And to decrease glucagon secretion, and glucagon is the hormone that tells the liver to keep pumping out more and more glucose. So by decreasing this, we get decreased hepatic glucose output. So we inject incretins, we get a direct effect. DPP-4 inhibitors work from the fact that these, when our intestine makes them, are there and gone in a flash. So if we can keep our own levels up by inhibiting the enzyme that degrades them, we keep our own levels higher. So I'm not going to talk about the differences between these too much. Again, not my data. This is a review study of the efficacy between the 3 drugs available in the United States. A1C, fasting plasma glucose, and postprandial glucose changes are relatively the same. No dramatic differences to choose between these drugs. Saxagliptin is the one that is metabolized through the liver with a CYP substrate system, so maybe having some more drug interactions. So for patients on numerous other medications, something to consider. And linagliptin has a single dose where the other ones have multiple doses, because linagliptin is not going to need to be renally adjusted, as it's primarily excreted through the enterohepatic system, where the other drugs do need to be renally adjusted. So again, I have a lot of older diabetics with declining renal function. This might be a reason to choose that over the others. In terms of DPP-4 inhibitors versus sulfonylureas, again, both work in some degree by getting more insulin secretion by the pancreas. Sulfonylureas, brisk, work much better, but only initially. As time goes by, that effect wears off, just like we saw on the prior slide. The benefit here is we're seeing a little bit more of a persisting effect over time. Now we get to safety. Again, this is a cardiovascular symposium. Cardiovascular safety. Review of 70 trials. 23 weeks or more in duration. The problem we're going to see with a lot of these slides is a lot of the studies are in the half-year to year time frame, and from what we said before, cardiovascular separation really takes a lot longer. But at least in these larger numbers of patients retrospective studies, we're not seeing an obvious sign for increased major adverse cardiovascular outcomes or death. We die less. So one of the prospective studies has been done with saxagliptin. It's already completed. They said no obvious benefit or increased risk for cardiovascular events. The 2 other major drugs are having their studies that are going to be completed either later this year or in the next few years regarding cardiovascular events. Why are these drugs potentially better to use? Maybe more durable therapy, and again, especially compared to glipizide, look at these hypoglycemia rates that we're going to see with these drugs. The relative risk of these are going to be substantially higher with sulfonylureas compared to glipizide. Numerous more adverse outcomes in the glipizide treatment group. Again, a lot of these are going to be hypoglycemia related. There are a few more deaths in the saxagliptin group in this study. It's explained in there that acute myeloid leukemia, which probably didn't develop in a short-term study of these two drugs, and salmonella and head injury, I don't know how much these could be related. They said they didn't think that these deaths were drug-related. Now the incretins, again, we're now, instead of trying to get your levels from your intestine higher, we're just going to inject you with industrial strength levels of these things. Endogenous, again, 1.5 minutes half-life. Exenatide, the first one coming to the market, twice daily injection, half-life 2.5 hours. Liraglutide, second to the market, 13 hours. Most recently, exenatide administered 1 weekly. I was actually unable to find half-life data. And this is where it's the same molecule as this, but complex to a polymer that dissolves slowly. And it's described in one of the articles like the dissolving stitches that the surgeons use. So the half-life is presumed to be very long, once weekly dosing. Great for patients who have compliance issues and they can administer or have someone help them just once a week. Use with insulin, why choose one versus the other? Exenatide BID and liraglutide have been approved with insulin use where the once weekly has not. Something else in here is that exenatide, either with the short-acting or the long-acting version, does have issues with metabolism differences between that and liraglutide renally. So this exenatide does require renal adjustment where liraglutide does not. The concern with these medications is that in rats, we've seen an increase in thyroid C-cell tumors, which would be things like medullary carcinoma, not seeing necessarily an increased risk in humans, but there's a warning not to use them in patients who are at increased risk for medullary thyroid carcinoma, specifically patients with something called MEN2 syndrome, something that I probably need to know about that hopefully you don't need to know about too much. And that in other thyroid cancers, papillary cancers, they do see GLP-1 receptors on some of these cancer cells, but whether or not this really increases the risk of these cancers is not clear. So let's say head-to-head when we're picking between these drugs and other drugs, I like this. These are usually short-term studies, 6 to 12 months. This is going to be when we're going to be on glimepiride already and we're going to either add rosiglitazone or we're going to add liraglutide. Liraglutide shows more A1C reductions. On metformin, adding either glimepiride or liraglutide, similar A1C reductions. Short term, we anticipate that hopefully this benefit is going to persist and this is going to wear off. Versus glimepiride starting monotherapy, we actually see improved A1C versus glimepiride short-term study. Metformin and rosiglitazone versus placebo, adding on, we see still A1C reductions when we're adding on to these other classes of drugs. And then with metformin and glimepiride versus adding glargine, we actually see maybe even more benefit. I don't think this is statistically significant, but maybe even a little bit more benefit with liraglutide compared to adding glargine short-term study. Within a short-term study, a relatively large weight benefit, liraglutide versus glargine. How about exenatide weekly? So this is where exenatide did head-to-head with a couple different drugs, starting off with, against themselves, BID, and both lowered A1C fairly similarly. For patients on metformin who are already on pioglitazone or sitagliptin and then discontinuing those and switching to exenatide long-acting, we saw that versus sitagliptin, A1C dropped further, versus pioglitazone, things were stable, but patients lost weight with this switch. Again, short-term studies versus glargine, very similar to liraglutide, similar to slightly lower A1C lowering. Short-term studies against all these other drugs. Head-to-head, we see that pioglitazone has a trend towards slightly more A1C reduction, metformin similar, sitagliptin slightly less. And then compared to, again, another head-to-head study, in this situation, they saw that there was a benefit. And this is not surprising. If you look at the 52-week data, at around halfway through, you saw this difference as well. Duration of benefit, I just picked an exenatide slide. Again, this is more of a reminder that you don't see the glucose trends shooting up like sulfonylureas, up like this. We see duration of benefit going out to getting closer to 2 years. Now, when we're going to choose between liraglutide and exenatide twice daily, this is a study that was done by the people who make liraglutide, and they saw that A1C did drop a little bit more with their drug versus exenatide BID. There's a little bit more weight loss. Serious adverse events are listed here. You can read over them. We're talking mostly about nausea, which was actually a little bit better in the liraglutide event as well. We talk about, oh, these drugs don't have hypoglycemia. We're mostly talking about major hypoglycemia. Almost any glucose-lowering drug can cause minor degrees of hypoglycemia. And both of the cases in both of these drugs that had hypoglycemic reactions that were considered more severe were with use of sulfonylureas. And we'll try and talk a little bit more about pancreatitis and pancreatic cancer risk in a moment. But in this study, again, there was one episode and thought to be chronic, actually not related to study drug. Now, this is the reverse, which is where the exenatide people sponsored this study, and they're looking at their weekly version versus daily liraglutide. Again, short-term studies. We're seeing A1C reductions in both groups. Liraglutide actually is still showing that it's probably a little bit better, regardless of the starting A1C point. And we do see actually slight improvements in weight loss in liraglutide versus exenatide. And when we look at adverse events, the longer and longer of duration that these tend to be, the less and less of the GI side effects we tend to see. So we see decreasing GI tolerability issues. We do see some increasing injections, and I've had a couple people who do develop nodules at the injection site. I've only had one person where this was persisting much longer than desirable and uncomfortable, where he's still not using the drug. And again, in this study, not a lot of pancreatitis, again, short-term studies. So about the concern about pancreatitis, last summer, joint groups came out with their statement on pancreatitis risk, that there is already an increased risk of pancreatic malignancy and pancreatitis in patients who have type 2 diabetes. In early insulin resistance, they're flogging their pancreas to try and get more insulin production. This is probably not good for proliferation of pancreatic cells. So there is concern from an epidemiologic study, but with current 80,000 patients or more in ongoing cardiovascular outcome trials, they're monitoring this very closely for pancreatic problems, and none of these trials have been terminated early for an obvious increased risk of pancreatic problems. A pooled study of prior exenatide BIT use showed current use without an increased risk of pancreatitis. I don't have an explanation for past exenatide use potentially being related to this. Maybe this is people who are choosing to discontinue because they were already having other problems. We're going to see this with ongoing studies. We have retrospective studies on liraglutide versus exenatide in cardiovascular outcomes, and crosses unity here, but may have a trend towards improvement. I'm sorry, this red didn't show up very well. Crosses unity, but may have a trend towards some cardiovascular benefit. And we have two prospective ongoing studies that are big, long, and going to look at cardiovascular and also look at that pancreatic risk. We've got the liraglutide expected to complete next year, and the exenatide study, which is actually still enrolling, and we're not going to get that data for several years. The newest kid to the market is going to be the SGLT2 inhibitors. This is where in your nephron, we're going to have SGLT2 as something that helps with reabsorption of glucose so that we're not peeing out our sugar all day long, much more potent than SGLT1. And since this is involved in around 90% of absorption of glucose in the nephron, if we block this and therefore pee out more glucose, blood glucose is going to come down. So this is a dosing study, and I liked it because it just had sitagliptin here as a comparator. The lower dose of canagliflozin, which is the first that came to market, seemed to be very similar to the 100 milligram dose of sitagliptin. And the higher 300 milligram dose, we saw a small improvement compared to that. On weight, we saw that there's some weight reduction. Again, these are relatively short-term studies, but we do see some weight reduction with the lower dose, even more so with the higher dose, and much more so, relatively speaking, compared to sitagliptin. Compared to glimepiride, canagliflozin, we do see so that the A1C comes down, not quite as much as the sulfonylurea again, but as should hopefully be a recurring theme now, sulfonylurea starts to wane relatively early. We see a more durable effect with these drugs and slight benefit with the increased dose. And then when we look at the events of hypoglycemia, again, sulfonylurea much higher. At the two different doses, much lower risks of hypoglycemia compared to a sulfonylurea. Head-to-head against sitagliptin, again, a little bit more A1C lowering, a little bit more fasting plasma glucose. Sitagliptin, again, mostly a little bit more postprandial effect for mechanism of action, and more weight loss with canagliflozin. Canagliflozin side effects, as we're peeing more sugar out in the urine, genital infections, yeast like sugar. So if there's more sugar down below, patients may get more infections. These were able to be treated like normal infections in the studies, so it's not like they were mega infections that required weird antibiotic regimens. We see more urinary tract infections primarily in women more so than in men, just because women get more UTIs. In several studies, hypoglycemia rates fairly low to placebo and sitagliptin. None of these are big hypoglycemia risks. One of the reasons why this is not a green as good is we just have limited long-term cardiovascular outcome, and there is some potential downside to this. LDL levels may rise, but they said that the LDL to HDL ratio didn't really change too much. So what does this mean in terms of long-term cardiovascular risk? We will see over time. It does make you pee out more sugar. It does work as somewhat of a diuretic. The blood pressure does drop a little bit, so that's a benefit for some patients. Cardiovascular, again, retrospective studies of the newer one to the market, dapagliflozin, potentially showing some decrease in cardiovascular outcomes but not crossing unity. And then we have ongoing prospective studies in both of these, dapagliflozin and canagliflozin. Both of these are not going to be reported anytime soon. So what are the other concerns? Maybe I should have put this one first. Canagliflozin probably came to market first because they didn't have an increased cancer signal in their studies. Bladder cancer risks were thought to be potentially a little bit greater with dapagliflozin, as was breast cancer. So how big of a deal is this? This is where the FDA is making sure that they're monitoring for this ongoing. Alpha glucosidase inhibitors, these have been around for a long time. I was told when I was in training these are weak. How much are they going to really help? I'm going to say that the A1C lowering in the variety of studies I've seen is from 0.5 point to 1.5 points. That the two drugs that are on the market are relatively similar. The acarbose, which is the one that I exclusively use, also blocks another enzyme as well and has less systemic absorption, so less risk of systemic side effects. It works primarily on slowing carbohydrate absorption, breaking down long-chain carbohydrates to glucose monomers that you're going to actually absorb. So it's primarily on a postprandial reduction in glucose. So if you hand this to the patient and they only test their blood glucose first thing in the morning, they're not going to see major benefits. They're going to be discouraged and quit. You have to look for the A1C, or you have to be getting to do some 1 to 2 hour postprandial glucose readings. We do see some possible improvements in triglycerides weight and glucose excursions. There's just less variability. And head-to-head versus sulfonylureas in one study, again, probably a little bit weaker. The major downside to these drugs is they slow carbohydrate absorption. Whoops, this means more carbohydrates getting further down in your intestine, and that means more for the bacteria. And bacteria make gas out of carbohydrates, so people fart more, and I tell them they don't die from farting. Maybe their partners do, but they don't. And it may decrease iron absorption a little bit, so if you have someone with iron deficiency, I'm just trying to make sure that they're getting their iron and this is being monitored. And that since it slows carbohydrate absorption, if they're on multiple drugs, and other drugs can cause hypoglycemia, that if they do have a hypoglycemic event, they should use glucose tablets and not food. Don't go going for that candy bar because they just ingested a medicine that's going to slow how quickly their blood sugar comes up with these drugs. Why should we think about using them? They lower blood sugar a little bit. Again, this is 2004 survival curves. I seem to die a little bit less with acarbose than placebo. So that's a good reason for potentially considering the drug. One of the other newer medicines to the market, but an old school medicine, are the dopamine agonists. And we have one, bromocriptine, released in 2009. So this has been around, and I've used this for much longer for pituitary hypersecretion, patients who have prolactinomas. This suppresses prolactin secretion and has other roles that I use it for sometimes as well. I find that this is poorly tolerated in those patients. And guess what? I think that bromocriptine for diabetes is also not very well tolerated. How does it lower blood sugar? We don't really know. It must have something to do with the nervous system effects throughout the body, appearing to improve insulin sensitivity and hepatic glucose production. How much A1C lowering data do we have? Since this is a drug that was really approved for non-diabetic causes long ago, they didn't have as much of a requirement for their data. And we have 2 short-term studies showing minor A1C drops, 1 longer study showing a little bit more of a drop at a higher, at these higher kind of starting A1C points. Again, my point with tolerability is, number one, that it only comes in 1 dose. The effective doses is somewhere between 4 to 6 pills. So I've got a patient who's on 3, 4, 5 drugs already between diabetes, cholesterol, and blood pressure medicines, and I'm telling them start 1 pill, and then 3 months from now, if I see you back, you're going to be taking 6 more pills in the morning. This is somewhat of a hard sell. And then when we look at completion of 1 year, this is their drug study. How many people were still on drug? Only about half of people because of GI tolerability and sometimes some lightheadedness. Does it work? A1C comes down. This is with sulfonylurea comes down. We start to see waning effect. This is monotherapy. We see A1C comes down. We see a little bit of waning effect. This is waning effect in just 24 months. And the maximum that we're seeing A1C lowering acutely is 0.8, 0.9-ish, and then by the time we get to the end of just 24 months, again, we're not seeing brisk A1C reductions. Why consider using this drug? Well, if you just need a little bit, you have reasons to consider using it. Again, cardiovascular safety. Time to combine cardiovascular events is less with this than with that. Again, do we have good data as to why this is really occurring? Not really at this point. Colesevelam, I think that's how you pronounce it. Unfortunately, I call it by the brand name, which I was told not to use. So this is where the mechanism of action is also not entirely clear. An abridged Cochrane review of, again, short-term studies with a modest number of patients does show that you get a little bit of A1C lowering, you get a little bit of LDL lowering. In larger retrospective reviews, in terms of cardiovascular risk reduction, we do see that there appears to be some reduced in acute MI and stroke hospitalization. But at the end of treatment, people aren't using this drug. So this is a reduction for people. This is not an intention to treat. This is who's still using the drug. Intention to treat shows a lot less benefit because people don't stick with this. And this is, again, 6 pills in the morning, or you got to put a powder in water, swirl it around, and slug it down. And you can't take it with certain other drugs because other drugs stick to this bile resin as well. Interestingly, they said potential interactions, and then on a list of not interacting, I saw the same drug twice. I don't know, this is not my list. But these are drugs that have interactions, and a lot of these are not uncommon. You know, there's the diabetic drugs, thyroid hormone. How many patients with thyroid hormone? I got to now get them to take their thyroid hormone well away from this drug. This is a problem. Can have interactions with oral contraceptives. So there are some issues with the use of this drug. Long-term cardiovascular data, just what I showed you already. And then last but not least, since I'm down to under a minute, so I'm getting just there, I'm going to start off by saying on that slide about drug costs. Look back at the slide on the drug costs for this. This is huge. This is, the niche product is that this is the only one FDA approved for type 1 diabetics in addition to insulin therapy. May have some effects on slowing gastric emptying and decreasing postprandial blood glucose because this is synthetic amylin, which is a peptide released with insulin at the same time that has some effects on the liver, decreasing hepatic glucose output. And we see that there's some mild weight loss and mild A1C reductions. And in a meta-analysis of, again, relatively short-term studies with relatively fewer people, there does not appear to be increased risk of cardiovascular outcomes. But to me, I don't know about a 0.3 to 0.6 A1C reduction for the cost that's there. So I'm basically out of time, and I squeezed a whole bunch of slides into just 40 minutes, so here we go. Questions? Okay. Yes? Okay. And that's because everyone's confused about a lot of stuff, and that's why the American Diabetes Association says we're not clear. But I'm sorry,
I know
you're
you didn't
confusing.
talk about it, but what I do a lot is start with metformin, and then I try to convince people to go on insulin. And
Okay.
I do that because I can adjust the dose of insulin, and it's really harder to adjust the doses of these medicines.
It's harder to adjust the dose of these medicines?
Well, I'm saying that people's blood sugar is different every day, and we tend to get them on the same dose of a drug orally, but we
Yep.
can adjust the insulin much more easily.
Okay.
And I know if I can convince them to inject themselves, I think I have relatively good drops in A1C. So is there any, what would you say about that?
So there, I think as an endocrine physician, where I would say that of the diabetics that I see, 90% of them are on insulin. I don't have an aversion to insulin. They're going to have more weight gain. Again, I didn't talk about insulin in the study. They're going to have more hypoglycemia. That's somewhat of a hard sell. And I would say that if you are downloading their glucose meters and seeing their logs and really helping them to learn to self-titrate, that's great. I'm going to say that, again, the head-to-head studies with exenatide and liraglutide specifically show that you can actually get A1C levels lower than you are going to be with glargine, similar to actually lower with weight loss, which patients tend to love. My thought is that early in the game, all of these oral diabetic medications, as long as they're not having negative side effects to them, and we're getting A1C lowering, and A1C lowering is going to reduce the risk of retinopathy, neuropathy, and nephropathy, is better, and that hypoglycemia, bad. So hypoglycemia, more cardiovascular negative outcomes, A1C lower, less microvascular outcomes, and we're still waiting for a lot of data on the long-term cardiovascular outcomes of these other drugs other than hypoglycemia, bad. So if I have a younger patient and I can get them on oral medications, I feel that I can drive their A1Cs down along with diet and exercise. And I have patients who come back to see me where we get A1Cs in the 5% range. They're not having adverse side effects. Should we start backing off on their treatment? I will in certain circumstances. But for the patient who has severe retinopathy and every note I get from the ophthalmologist is about how they need to do even better, then I push these. I think that lets me push them A1C down with less hypoglycemia, and I think I have the data to back that up. So if we could talk about more later. So I guess back here we have someone. Yes, hello.
Thank you for the informative talk, by the way. A question. I understand that with A1Cs there are pros and cons in terms of monitoring and diagnosing diabetes, but I kind of wanted to see what your thoughts were in terms of the discrepancy between A1C and fasting glucose. I'm not sure if this is a lab issue or
Okay, so this is actually a much larger talk, and the last time I spoke here about 3 years ago, I did a whole talk on this, and I'd be happy to talk about you separate time, because this is not a 1-minute answer. There are definite problems with A1Cs, not to be racist in any way. I see your African American, Middle Easterns with an increased risk of aberrant, not normal hemoglobin, sickle cell, other hemoglobin subfractions. The A1C can be really unreliable. Patients with renal insufficiency, in a lot of my notes, I'll say this patient has renal insufficiency. I don't think the A1C correlates. As a practitioner, I get A1Cs because I need to. Patients expect them. I actually look at the blood glucose meter downloads a lot more than I look at the A1C, and I make my decision on that.
When do you use fructosamine then?
Fructosamine, I do. There's just not good long-term data on it, and it fluctuates much more quickly, but I do check it sometimes.
Will you comment on the difficulty, in terms of insurance companies, what they pay for? They like metformin, they like sulfonylureas, and then you get into expensive drugs.
Yep.
And yet, what we know is that sulfonylureas in the elderly, or people with comorbidities, are very dangerous.
Yep.
And yet, insurance companies are forcing us to do sulfonylureas rather than DDPIs. How do you deal with that dilemma?
I spend an awful lot of time doing prior authorization forms. I mean, that's a simple answer. And my staff people know this. I'm spending a lot of time doing prior authorization forms. So I get them, and they're not on sulfonylureas. I also download blood glucose meters, and when you can see these large swings in blood glucose with the blood glucose meters, and you can document some hypoglycemia, and you've seen my notes, they're very wordy, and I talk about all the reasons why I don't think they should be on them, I get them off of these drugs. The patients that are on sulfonylureas are patients who often don't want to switch because of financial and other issues, adverse reactions to other drugs. I'm sorry. Maybe one more. I don't know where we have time.
Yeah, one more.
Okay.
Sure. So you're talking about downloading these fingerstick blood sugar results.
Yes.
And in our type 2 diabetics, they get 1 blood sugar to do per day.
Yep.
I don't find that helpful, but there is that I've heard proposed, which is 1 day a week, do 7 blood sugars before and after each meal and at bedtime, and see what help the patients learn how to see what.
There are numerous ways to do this. There are limitations in what Medicare will cover with the average of 1 a day. And I have several different ways I do this. I have patients where I have a log sheet and I circle, I want you to get some pre-breakfast, some pre-lunch, some pre-dinner, some bedtime readings, different times of day, where I ask them to do before a meal and after a meal on a given day to look at this, and I ask them to do those pre-meal and post-meal ones to write down what you're eating and see which meals you jump up higher with, all this kind of stuff. So I do that, and I find downloading the blood glucose meters is hugely helpful because and needing the logs of what they've eaten at the same time is how I help people with their dietary management. So average of 1 a day doesn't mean that they're necessarily testing 1 a day. I have patients I see where they're testing morning, and all the blood glucose is within 15 points, and I say, stop doing this. It tells me absolutely nothing. Anyways, so sorry. Thank you.
Thank you very much.